Good morning, everyone, and welcome to the annual Ruth Abramson Memorial Lecture. This award is presented annually to a clinician who demonstrates exceptional humanism as part of their regular practice. The award honors an individual for serving as an inspirational role model to students, residents, faculty, and staff, and exemplifies humility, leadership, and professionalism. Dr. Abramson was a nephrologist and a pillar of the Mount Sinai community for over 40 years before her passing in 2004. She was a beloved teacher, a renowned researcher, and a dedicated clinician, and she inspired hundreds of young physicians during her years on faculty. This year's recipient is Dr. Demetre Daskalakis, Associate Professor of Medicine and Infectious Diseases here at Mount Sinai and the Deputy Commissioner for the Division of Disease Control of the New York City Department of Health and Mental Hygiene. Dr. Daskalakis received his MD from NYU, completed his residency in internal medicine at Beth Israel Deaconess, and his fellowship in infectious diseases at Harvard's Partners Healthcare. He later completed MPH at the Harvard School of Public Health. Prior to arriving here at Sinai, he worked at NYU, where he provided clinical care to individuals with HIV, conducted HIV prevention research, and developed several groundbreaking public health projects. He arrived at Sinai in 2013 and served as the medical director of the health system's HIV program, overseeing initial efforts to merge one of the largest HIV primary care programs in the country. Since 2014, Dr. Daskalakis has also worked at the New York City DOH, and in his current role oversees all infectious disease-related public health programming in the city. In this role, he has been at the front lines of the emerging COVID-19 epidemic. We are fortunate that he has taken time out of his busy schedule to speak to us. Please join me in congratulating Dr. Daskalakis on this well-deserved award.
Thank you, everybody. So good morning, and thank you for those of you who are joining via virtual means. Today, I'm going to, while we're in the middle of the beginning of a COVID-19 scenario in New York City, talk about this virus as really a primer for healthcare providers, so giving you a view. So again, as I stand up here, everything that I say to you is out of date. And so we'll start by saying that we know that this is evolving rapidly and that it's the best knowledge that we have as of the date that we've updated the slide deck. So what I'll do today is give background, review the current status of the outbreak, talk about some clinical features, talk about clinical guidance, healthcare guidance, talk a bit about the current status of managing contacts with COVID-19 exposure, talk about our efforts to prevent community transmission, guidance in anticipation of a pandemic, and then just talk about the resources that we have. So I think we all know through media and through our own reading that COVID-19 started as an outbreak of respiratory illness of unknown etiology in Wuhan, in the Hubei province of China in December 2019. We were first alerted of 40 cases with a history of exposure to a live animal market that suggested animal to human transmission. Chinese scientists rapturously identified the novel coronavirus. Again, a really important consideration how quickly this all has moved from there's an outbreak to we have a virus. Then came the naming of the virus, which they need a better PR person for the virus. So they called it SARS-CoV-2, and the syndrome is called COVID-19. So technically, SARS-CoV-2 causes COVID-19. In New York City, we just call it COVID-19. It tends to be a little bit clearer than SARS, which is anxiety-provoking for many people. In terms of coronaviruses in general, we know that coronaviruses do exist in animal reservoirs. There are many types that circulate among humans. There are 4 types that are pretty common that cause mild to moderate upper respiratory tract illness. You can see their names up on the slide. I'll remind you that some of your molecular diagnostics actually test for some of the more common. So if you're using platforms that include these common coronaviruses, it's important to remember that a positive test on one of these rapid molecular tests that we have right now, if it says coronavirus, it is not COVID-19 because that is not included in that respiratory panel. There are also the zoonotic transmissions of coronaviruses that we know about. And so we have our first, which was SARS-CoV. So probably all of them are zoonotic transmissions, but the most recent ones, 2013, caused more than 8,000 cases, and we've had none since 2004. MERS-CoV emerged in 2012, caused over 2,400 cases, and every now and then we hear of cases throughout the world. And then there's this one, SARS-CoV-2, causing COVID-19, that emerged in 2019, and the outbreak is ongoing. So again, this slide is out of date. So by standing up here, it's already wrong. There's widespread human-to-human transmission on multiple continents. I think to date, there still has not been a transmission in Antarctica, but otherwise every continent has COVID-19 activity. There are greater than 105,000 cases, over 3,500 deaths. Most of the cases are in mainland China, and now the good news is, which hopefully is a preview for us, is that the cases in China are now decreasing. However, other countries in the world are not so lucky. We're seeing sustained transmission in South Korea, Japan, and Italy and Iran, and Italy now is the runner-up after China. This is what our story looks like. So the current status of the outbreak in the USA, very dynamic. There are 44 states with confirmed cases of COVID-19. There are greater than 500 cases among those. 36 of them are linked to travel, and there are 11 deaths. Those numbers are wrong. I think I actually saw a number up to 26 deaths in the US, but don't quote me. Media sometimes moves faster than the CDC. There is clear community transmission, so I would say that this is incorrect now. California, Oregon, and Washington are not the only states. We are also one of those states that we have clear community transmission. And I will say it's not just in Westchester, it's clearly also in New York City. There are, as of our last official report, 16 confirmed cases in New York City. That will change later today. So in terms of clinical features, a couple of things about this virus. The incubation period, the mean is about 5.2 days. The range is 2 to 14 days. The median patient age reported in China is between 49 and 56 years old. So apparently, at least in the Chinese experience, sparing younger people. I'm not sure if that's what we are going to be seeing in New York and the rest of the country. Non-specific initial symptoms, so most commonly a fever and a dry cough. I'm going to stop there for 1 second and say, in our current era, what we should be telling our patients is, if you have a fever, if you have a little bit of a cough, if you're not feeling so well, don't tough it out, stay home, and then we'll go deeper. So people who have a cold, who usually would come to work, because New Yorkers like to do that, they should consider maybe staying home. Should they go to healthcare? No. They should wait a minute. See how they are in a few hours. See how they are in 48 hours. If they're better, stay at home until you're better for 72. If you're not better, call your doctor. Don't go to the ER and urgent care. See if the doctor gives you advice and says stay put or come in. And when you come in, you mask and do all the right stuff. So really, we should be preserving the healthcare system for the sickest patients and not doing well baby visits and well patient visits for people who have a little sniffle, because that's going to actually maintain the infrastructure so grandma can have chemotherapy and that we can do a catheterization in someone with an MI. So really important to hear that. Less frequently, although I think we have seen in some of our cases myalgia, so it seems it's very flu-y, headache, sore throat, and occasionally we hear about diarrhea. Transmissions are mainly via respiratory droplets. There's direct or indirect contact. So there's a big debate raging right now about how long does coronavirus live on a surface. New York City says it probably doesn't live very long. Other sources say it's like 10 hours. Other sources say it's 15 hours. Other sources say it's 6 days. So the reality is that that lab conditions are different than real conditions. So most likely what lives in the lab does not live as long in real life, but why chance it? So the right guidance is hand hygiene. So if I can't answer the question, let the scientists debate it, but the answer is straightforward. Squirt your hands with alcohol. I have a picture of your beautiful sign to take back to my people. I squirted my hands with your lovely alcohol-based hand sanitizer. Coronavirus sees alcohol and screams and dies. So even looking at that sign probably killed some coronavirus. So hand hygiene, really important. So again, mainly droplet transmission. There is no evidence of airborne transmission to date. Footnote, like right now, you have people on airborne precautions. We need to advocate for the CDC to change to droplet, because that way you preserve your AIIR rooms, which are your negative pressure rooms, and you don't run out of N95 masks for your TB cases. So think about that. So an important thing to think about. Fecal oral transmission, it's up to debate. There may be SARS maybe had it, but we're not sure if this has it. And The risk group for severe COVID-19 is over 65. Actually, the mortality starts to increase when you're over 50. So at least in New York City, our guidance is that you should have a lower threshold to have testing for people under 50 because we want to identify those people earlier and move them to healthcare as they need to be. So it may change as the outbreak increases. But for now, that's what we've got. And then also comorbidities. Interestingly, diabetes is really high on the list. But cancer, chronic lung disease, all of the things that we usually consider a lowered immune system. Because I do HIV, I'm always asked about HIV. Don't know yet, don't have a lot of experience in that, so that's something that we're going to have to learn more about. In terms of the severity of the laboratory confirmed cases in China, that means laboratory confirmed. That, remember, like, we have a lot more than laboratory confirmed in the world. 80% of them are mild to moderate. If you have a sniffle, stay home from work. That's how you prevent coronavirus transmission. 14% of them are severe, and that means they had dyspnea, hypoxia, tachypnea, and lung infiltrates, and 6% were critical, requiring some kind of ICU level support, whether it's respiratory or if it's pressors. In terms of the hospitalized cases in China, this is one case series of 138. 54% were male. Median age was 56 with a range of 22 to 92. Hospital-associated transmission suspected. So what they found was that by bringing people into the hospital, you're potentially creating more cases. So really important to focus on trying to keep people out of the hospital who don't need to be here. CTs showed that they all had bilateral ground glass opacities. Of the 36 in this case series transferred to the ICU, 61% had ARDS, 66 years old. The younger they are, the better they do. Does that mean that every young person who gets this virus will do fine? No. What is this virus like? It's like flu, just like flu. And so that's what you would expect to see as well. There could be some people who are younger who may not do as well. And comorbidities underlie 72% of their medical histories. Some laboratory stuff that we're actually seeing play out in the cases that we have. Lymphopenia, we've not seen a lot of prolonged prothrombin time. We have seen elevated LDH. So in the cases that we have in New York so far, we do see some of these lab abnormalities. Signs and symptoms, fever, dry cough, and fatigue. So those are the things that we see. So then there's a larger series, and this is over 1,000 cases, again in China. These are lab-confirmed hospitalized cases, and this is actually over 500 hospitals that were involved in 30 provinces. So not just Wuhan, because it's just an interesting view other than Wuhan. Median age, a little bit younger, 47, 42% female, and the outcomes were that 5% were admitted to the ICU, 2.3% were on mechanical ventilation, and mortality was a little bit less than 1.5%. Signs and symptoms, they had fever and cough as the main thing. I think one of the interesting things is that some of the people didn't have fever when they were admitted, but ultimately they all developed a fever. So that also means that they were bringing people in who are a little bit less symptomatic, probably unnecessary. So just to think about that a bit, like sniffles, stay home. Little cold, stay home. Maybe even little fever, stay home. If you have fever, shortness of breath, and cough, especially if you have comorbidities, especially if you're older, consider a test. So that's really the message that I think I'm getting across by saying it over and over again. So in terms of treatment and prevention, this is one of those moments that I sort of go back to H1N1. So H1N1 was our last pandemic. And the thing that's different about this versus H1N1 is that we have no vaccine and we don't have treatment. So the only things that will work are not countermeasures, but social distancing and other things, the non-pharmacological interventions that you need to control an outbreak. Vaccines are being developed in the US, China, and elsewhere. We always get these optimistic, we'll have a vaccine in a month. Well, no, it's going to take a lot longer than a month because of evaluating its safety and efficacy. It will probably not be ready for at least a year. Current medical care is supportive. So why is that important? when you identify people, someone who has comorbidities and risk factors and they're a little bit sick, and you admit them and have a hospital that can work, you can support them through their pneumonia in some cases and they survive. If the health system isn't able to support the service, then we're going to have people who are going to have worse outcomes. So that's why it's so critical to support the work that you all are doing. Are the most important recommendations that avoid corticosteroids unless indicated for other reasons, and in terms, so they ended up doing worse if they were on steroids. There's also a drug, remdesivir, that is being studied, and it actually has, I'm not going to read them, but criteria for who would qualify, and some of them actually knock out some of the sicker patients. So a creatinine clearance that is lower, LFTs that are high, and vasopressors would then exclude someone. So it is pretty much focused on individuals who are only moderately ill. You can also learn more about clinical guidance and management by the CDC, and you can just look at their website is actually really great if you want to take a look. Okay, current healthcare guidance. So this is going to evolve every day. So it's one of those things. One of the things that we get is that a lot of our messaging seems like inconsistent from day to day because it's changing from day to day. So really what you're doing here is go to a trusted source. And if you and we are one, the New York State Department of Health is one, the CDC is one, really keep an eye out because things are extraordinarily dynamic. One day I have guidance that says one thing and the next day it says something else. And so it's just how it is right now. The webpage is updated with some of our stuff. There's a couple of posters that are great about fever travel. We release our health updates, and again, our website has a lot of info. Also, providers, not patients. Providers can call the provider access line, and that's the number on the screen if you have questions or any other issues, or if you're ordering a test, and I'll tell you who you should be sending our way. We will continue to do webinars. Those have been very well attended. In fact, I think the last city-state webinar had over 4,000 folks who logged in. So very popular, and I think a lot of great questions come up from there. In terms of general facility preparedness, it really goes back to what I just said. It's changing every day, so please continue to sort of watch what's happening and use trusted sources rather than some of the other media. Educate staff regarding current status of the outbreak, and please feel free to press forward on all of our health alerts. So we have a lot of good information in there and then resources that are linked within. Again, general infection preventative measures are really important. So I think we've heard some of them, like again, the alcohol-based hand sanitizer should be your best friend if you can't find a sink or soap. Practice really good hand and respiratory hygiene. I think everyone's seen the picture of Mayor de Blasio coughing in his elbow. Cough in your elbow, cough in your sleeve. Try not to cough in your hands. Like, I know everybody in the world loves to touch their face. Like, try to not touch your face. Like, it's a little game. Like, every time you do it, maybe you penalize yourself, do something to remind yourself, no touching your face. Also, again, and I can't emphasize it enough, if you're sick, stay home. So everyone who lives in New York knows that we're tough. And what tough means, I go to work even though I'm sick. Not this year, you're not. This year, stay home. It's tougher to stay home than to come to work. It's braver to stay home than to come to work in this scenario. So, what do you do in terms of pillars of COVID-19 preparedness in such an environment? So it's in this order: identify, isolate, inform. That's what we really need to have happen. And now this is going to change a bit as you and others are accessing other commercial labs that are able to test for COVID-19. So right now, Inform is Inform Us because you want testing. But I'm going to look at Gopi. Gopi, do you guys have LabCorp access yet? Okay, so that, excellent. That's good. That's, I know, and that's complicated. But identify, isolate, inform. So identify means find people who potentially have COVID-19. The word is possibly. And so as you are doing, as I saw walking in, post wonderful signs that tell people what's going on. Have them in as many languages as possible, and at healthcare entry points, directing persons to immediately notify staff of recent travel, although that is going to fade away as we see community transmission being the norm rather than the exception, fever, cough, or shortness of breath, and consider entry screening for patients and visitors, or even consider doing observed hand hygiene for entry visitors. So have someone post it and say, use the squirt, use the squirt. So there's a couple of strategies there. So isolate persons with COVID-19. So right now, today, if you have someone who you're worried about having COVID-19, ask questions after you isolate them. So put a face mask on the patient during the initial evaluation, put them in an AIIR if possible, airborne infection isolation room. I see patients on 25th Street and 7th Avenue at the Chelsea Clinic location at Comprehensive Downtown. Don't have such a thing. It's not weird that we don't have such a thing. A lot of clinics don't have it. That's fine. In that scenario, put them in a single room with the door closed and ideally put a mask on the patient while they're in the room. You also want to minimize the number of staff who enter the room, and at least at this point in this scenario, you want to keep a log of staff who enter the room in case you need to clarify, unless Gopi has to clarify if they need to be isolated or furloughed or some combination of the two. Also, use appropriate personal protective equipment while evaluating patient. That is standard contact and airborne precautions, including eye protection. Using standard precaution means that you can stay at work. So it's really important in that scenario to make sure that you're PPE'd up. Now, with that said, there's a lot of hope that that we're going to move in the direction that the WHO says and the direction that Seattle says. So realistically, coronaviruses are not transmitted by airborne mechanisms, but transmitted by droplets. So it is important to consider the rational move of PPE away from things that are burning your stashes to more scientifically at least inspired strategies. So again, right now, it's that level of protection. We hope that soon it will change to a appropriate but lower level of PPE. The next step, and I'm going to tell you how this is changing, is to inform us. So you don't have to inform us if you send labs to LabCorp. Why? Because you're not asking me for the lab. Like the really reason that you're informing us, it's not because we're not going to find out about it, because we're Big Brother. Like what you're doing is you're asking me for lab testing. So soon what's going to happen is when you send them to LabCorp, we have a very sophisticated electronic lab reporting system. And if there is a positive that you order at Mount Sinai, once it becomes positive in your EMR, we will also get that result in our electronic reporting. So there's no need to call for people if you're sending them to LabCorp. The only time that we really want to learn about people, no matter what, and it's fine for you to call us, to accelerate what we're doing, is if they're a healthcare worker, we want to know about that early on so we can make sure that we're doing all the right stuff. If they reside in a congregate setting, because those are way more complex, and if you think that the patient is a cluster of 3 or more confirmed or suspected cases in a congregate setting. So right now you call us no matter what because we're your source for testing. When LabCorp testing happens, it's tighter. So it's a smaller group of people that we need to hear about primarily because we will get the lab reports eventually anyway. So who to test? So we've actually done a little bit of a shift to try to focus our resources on the people who will have the worst outcomes of COVID-19 rather than sticking with case finding. So honestly, there's not a lot of reason to test someone who has just sniffles. It's going to make less and less sense to do that. It is more important to focus on individuals who are inpatients. Right now, it's a broad range of inpatients. It may change in the future depending on how many cases we get and how busy you all are. We may have to focus only on the sickest. But today, COVID-19 testing for patients presenting with acute respiratory symptoms. But the thing that's also important is before you send a COVID-19 test until it gets merged into your BioFire panel or whatever you use, make sure that you rule out other causes of respiratory infection. The rate of co-infection is less than 2%. So in effect, what that means is if you have ruled in flu, at least at this point in the game, you do not need to go on to a COVID-19 test. So that's really important. So testing may be particularly urgent for some people. And again, New York City is shifting from case finding to focusing on the sickest, again, moving into a new era of this. And what that means is 50 years of age or older, individuals with chronic lung or cardiac disease, malignancy, diabetes, or conditions or treatments that can lead to immune deficiency. Healthcare workers and people who live or work in congregate settings that include shelters or correctional facilities are also very high priority. So, in most cases, once you come online, please submit to a commercial diagnostic lab. So when you get your COVID-19 order set in Epic, do it that way. But we want to know about certain people, and we would rather do the testing in New York City, also because of our ability to sort of investigate further and more rapidly. So for patients in the intensive care unit with severe acute lower respiratory illness, we want to get those labs. And if the provider ordering the test does not have access to commercial, academic, or hospital-based laboratory testing, so until you have access to LabCorp or whatever you use, which I think is LabCorp, we will test other people as well. To submit specimens, there's something called e-order. You all are already on e-order. I don't have to worry about that. Nothing to sell to you. And also, if you will need to, at this moment, for those individuals, call the provider access line for approval. Lab testing, when you get it from LabCorp, there's no approval. It will be easier. What are the specimens for COVID-19? So realistically speaking, the two most important are nasopharyngeal and oropharyngeal swabs. So as of yesterday, we've gotten the go-ahead to use swabs that are collected and put in the same viral media. So instead of sending us one NP, one OP, you're going to be able to send us one viral media with two swabs. This just changed. In fact, it changed a few hours after we released our HAN saying not to do that. So we're going to have to update our health alert as well. Sputum, tracheal aspirate, BAL is also available, but optional, not necessary. And again, I can't say this enough, test for common respiratory things first. Use that BioFire, that big multiplex PCR panel you have, because if you find something else, you can back up, at least for now. Just to review again, infection control considerations, our current CDC guidance is standard, contact, airborne, N95, and then eye protection. If negative pressure rooms are not available, place in a private room with door closed. This is really outpatient guidance. This approach poses significant challenges for many outpatient facilities, and I think you all will agree with that. Also, N95 respirators are not in stock and unable to purchase. Healthcare providers may not be fit tested to use N95s, and to date, there has been no evidence of airborne transmission. So we need to advocate for a shift in PPE from the CDC to go back to what it actually makes scientific sense. So we have to anticipate that there are supply shortages, personal protective equipment, because there's decreased exports from manufacturing countries. Footnote, China is a big manufacturing country, so you'd imagine what's going on there. There's also an increase in demand, some rational, some irrational. So now we're utilizing some existing stockpiles, local, state, and federal, and it's important that you check with trade associations or healthcare coalitions for requests. There could potentially be shortages of medications and other medical supplies. About 3 or 4 days ago, we did a run to see if there are any obvious medications that are in shortage. Antibiotics or not, we don't sense or see anything yet that is in shortage, but just it's something to think about and plan. Hospital beds, healthcare personnel, and ventilators. I just want to give you something to think about. Right now, what we're doing with a healthcare professional who has a medium risk is that they get furloughed for 14 days. So we should think about advocating for transition of that furlough, not based on exposure, but based on symptoms. So in other words, right now, you should be doing exactly what I said, which is 14-day furlough. Ask Gopi, Gopi will tell you. I'm making you very popular, Gopi. I'm going to put your cell phone on my slides. But what we should be advocating for instead is, if you're a healthcare worker who's a medium risk exposure, go to work. If you're symptomatic, stay home. Stay home until you're better, fever-free and symptoms improving for some amount of time, and we're going to say probably 72 hours. Testing, not you'll decide. But ultimately, that's really where we're going with this. That because imagine, I'll just give you a story. It's in the news. It's not something that's a surprise. There's a hospital that had one case that was there back and forth a couple of times, and 41 healthcare workers have been knocked out. And then think about quarantine in general. So I know of a case of a Westchester environment, like a public gathering that was quarantined, and it happened to include half of the cardiology department of a hospital somewhere. So we really have to be more rational about our thoughts of quarantine and realize that where we are today is not where we're going to be tomorrow in terms of what we're thinking. So follow the guidance for now, but advocate for more rational guidance around quarantining healthcare workers. In terms of environmental cleaning, clean and disinfect room before returning to routine use. Really, it's pretty much standard. Use EPA-registered hospital-grade disinfectants effective against coronaviruses, and that's in the manufacturer's instructions. Most doctors don't have to think about this. I know one in the room who does. Also, treat contaminated waste as routinely regulated medical waste, nothing special about it. Clean all areas with focus on high-touch surfaces, and follow standard operating procedures for containing and reprocessing used linens. So now we're going to talk about efforts to prevent community transmission in the U.S. And I'm going to really bring up an important topic. This is where it gets like real public health, which is the notion of containment versus mitigation. And I will explain to you why the idea of a case investigation for each case, chasing the cases, is not important as making strategies for the community, and why you're seeing New York City in our media and our messaging starting to shift away from this like let's keep it locked down to more let's figure out how we can keep our healthcare system and other services afloat. So a couple of irrational things that were done by the federal government were creating travel restrictions after the cat was out of the bag. So January 31st, 2020, Health and Human Services declared the coronavirus a public health emergency in the U.S. and announced that there were travel restrictions effective February 2nd, 2020. So individuals who were foreign nationals who visited China in the last 14 days were not allowed to enter the U.S. So they had to be more than 14 days out. American citizens, permanent residents, and their families arriving from Hubei, that's Wuhan, within the previous 14 days were quarantined mandatorily for 14 days. And the rest of mainland China was told to self-monitor at home and do social distancing for 14 days. On February 29th, they added Iran. In the past 14 days, they may not enter the U.S. Then other areas entered the list. Level 3 healthcare notices were given for South Korea and Italy, as well as China and Iran. So what's interesting is that the CDC is providing us lists of individuals who are landing from China and Iran, but they're not providing us lists from individuals landing from South Korea and Italy. So there's a very stark inconsistency in terms of what we're learning. And again, it's raised to question what the real utility of this is anyway. There's a level 2 health notice against Japan, and New York City is actually currently saying that individuals coming back from Japan should also social distance. Check the CDC website for updates. So our current strategy, and I'll say current with a footnote, not really, but like our evolving current strategy is called containment. And that means quarantining high-risk travelers from high-risk countries, high-risk. So I'm an HIV guy, and calling people high-risk makes me angry. So countries that the federal government has identified as countries of concern, identify cases and contacts and isolate them, hand washing, routine influenza precautions, so those stay the same, but sometimes that becomes impossible. So when you have 2 cases, I'm going to take you an interesting place. This is me being the Masters of Public Health professor. Ebola, rare disease, 1 or 2 cases, 1 case really, poof, you can contain it. This is circulating in our community. It was probably circulating in our community for a while. And so now what we're doing is seeing the tip of the iceberg. All of the people, the 80% of people who are very low symptomatic are just hanging out in the world. And then there's a peak of individuals who are sick who are coming to healthcare, except that by over-testing, we're pushing that peak into finding some of the people who are less sick and bringing them to healthcare, where they're going to sit next to grandma who's 80 on chemotherapy and potentially give her coronavirus. Why it's important to stay home if you have sniffles and aren't feeling well, because you want to minimize that exposure, and why really containment starts to become impossible, and what you have to do is focus on more community-based strategies that include some social distancing, this stay home if you're sick idea, the raising the threshold to get people to healthcare. So you may want to see someone 4 months ago, someone with a fever and a cough, maybe you want to see in the clinic. Now, you don't want to see them in the clinic, depending on how well they are and what their comorbidities are like, as long as you give them really good advice about when to come back. So practicing whack-a-mole means that we can't really focus on what we're trying to do to end or control the outbreak in New York City and in other parts of the country. So shifting has to happen. We need to move to mitigation, and those things are happening as we speak. The goal is to minimize spread and mitigate impact. Again, I'm an HIV guy, and I use the word harm reduction. So this is harm reduction coronavirus rather than harm elimination. harm elimination, the ship has sailed probably before we even knew there were like 100 cases in China. So how do you do this? Individual, it's cough etiquette and hand washing. What we've said from the beginning of this outbreak is the same as what we're saying in the middle and what we're going to say until the end. Social distancing, work from home when possible. Is there a way to implement telemedicine instead of having live clinic visits? Limit the use of healthcare for worried well and mildly ill. They're the ones who have coronavirus. They're the ones, 80%, 80 are asymptomatic, are not asymptomatic. 80% are low symptomatic. Avoid unnecessary social gatherings. So today we're saying that. Tomorrow we may change what we say and say avoid large events. This is the sliding scale of the experience of scaling up a response to a pandemic. Extreme, currently not recommended, but may change, school closures, large gatherings, etc. And then environmental considerations, it's always good to make things cleaner than they already are. And so though a lot of that may be more anxiety soothing than reality, it's still good to sort of have strategies for cleaning. In terms of thresholds for when we switch, it's not about the number of coronavirus cases that we have. There are more data that we have that help us. So it's one of my favorite discoveries walking into the Department of Health and being a leader in this area is the power of what we call syndromic surveillance. So there is a system, and as a physician sitting in a room here years ago, I had no idea that every hour there is download of data from every emergency room in New York City and urgent cares. And what they do is they use doctor smarts to actually analyze the data. And so, you're a chief resident? Okay, I'm pimping you. Tell me what an influenza-like syndrome is like. And this is why he's a chief. So, that's right. And so what happens is you program your chief resident mind into my surveillance, and we say, are we seeing increases in ILI by using all those discharge diagnoses in ICD-9 or 10 or whatever we are at codes to be able to figure out if we're seeing it. And so what we're seeing in New York right now, and it's in the health alert, it's not a picture, but it says that we're seeing increase in influenza-like illness visits that are happening with fever that we're seeing in emergency departments and urgent cares. But we are not seeing an increase in influenza diagnoses based on viral testing. Interpretation, there's something causing ILI in New York City, and it's not the flu. So, most people are well with coronavirus. Stay home. If you're getting sick, don't come to work. Don't go to school. It's already here. And this is why you're seeing us say community transmission, community transmission. What that means is that it's not about the guy coming back from China anymore. It's about the fact that we all have to take care of each other and not come to work when we're sick. So that's really the important message. So your lab testing is interesting. The number of cases that we have are interesting, but my powerful surveillance data is more interesting to tell you the things that we can't see because of the inherent limits in accessing laboratory tests for everyone. The lab tests, frankly, are a rough tool, and what's a better tool is a sort of view of the world that we get through syndromic. So this is what the goal of community mitigation is. So the number of cumulative cases that we're going to have is probably going to be about the same, whether we try to do containment and say like Demetre has coronavirus and he can't leave, and then I talk to you and 6 feet away and you can't leave your house. So, or if we do more community-based things and stay home if you're sick, and if you're older, like avoid event, like if we do all of the stuff that's like social distancing, non-pharmacological interventions, what happens is instead of having this big high purple peak of the outbreak, we spread the outbreak out. Why does that make people nervous? Well, it lasts longer, the peak is less high, but it lasts longer, and the number of cases you're going to get, it's probably around the same. But what's the difference? All right, I'm not going to pimp you. It's too hard. You probably know. So when you have a high peak of new cases, let's say that let me see if this works. Let's say that right here, you have 1,000 cases. So if you do this mitigation strategy, you'll see you actually don't have a lot of cases at the same time you have 1,000. What does that mean? There's not 1,000 people knocking on your door looking for health care. What happens by lowering the peak is, the desire is, and this graph doesn't have a line, but right here should be the idealized line, capacity of healthcare. That's what this is all about. It's about you. So the idea is that by moving things away from like one case, two case, keep them in the who's gal, and instead saying like, let's work on community strategies, social distancing, work from home policies, if necessary, event closures. We're not recommending it today, right now. Like, if necessary, other closures. What you're doing is blunting the height, so you never have the day where there's 5,000 people or 10,000 or 20,000 people looking for health care, and they're so over capacity that grandma can't get chemotherapy and your dad can't get cathed. Does that make sense to people in the room? I know that the people outside can't. So that's what the whole goal of this is. So how does public health determine transmission? I've already told you. First, we watch out internationally and see what's going on, see what's happening in the country. I told you about syndromic surveillance. It's one of the coolest things that we've got. And we also launched what was an early detection system, which is lowering the threshold for testing. So CDC was saying only test certain people. New York City decided to drop the threshold. We dropped the threshold. We started getting cases. So definitely it showed us that there was transmission. There are still plans to do some sentinel surveillance. It's going to be retrospective. So keep an eye out for that. That'll be more of like a research thing after we're done with the entire experience. So what is guidance in anticipation of a pandemic? So if transmission becomes widespread, our guidance will evolve. So as things progress day to day, our guidance evolves. It's not inconsistent, it's just different. And it changes because the scenario is changing. There's going to be greater emphasis on home isolation and home quarantine. Okay, I'm going to pimp you again. What's the difference between isolation and quarantine? So actually, it says home isolation versus home quarantine. And so you have to come in and shadow me for a while at the Department of Health so you can learn these things. That's a B+, solid attempt. Isolations for sick people, quarantines for well people. That's the only difference. It's the same thing. Now, right now, a quarantine means you get an order and you're stuck at home. It could be that what's going to happen is quarantine yourself based on your symptoms. That's the direction that things are going to have to move in eventually. Quarantine and isolate yourself because you're sick, right? It's going to be different. So just get ready for that shift. Again, continuing individual measures is important. Hand hygiene, cover your cough, self-isolation if you're at home or sick. You need to do things that are social distancing. New Yorkers are very social in general. We don't like to do it, but as we get deeper and deeper, it may become deeper and deeper. So just really listen to us and listen to other trusted sources to make sure that you know what you're doing. And today I want to test people. Tomorrow I may not. So there will be a time, and I'm not being doom and gloom, but there will be a time where if you have fever, cough, and shortness of breath, you have coronavirus. So why would I test you? There will be a time. So it's going to change. So right now we're saying do not test asymptomatic or not very symptomatic people. Keep it ideally hospitalized. We want to get the ICU ones. We'll take other hospitalized ones if you want us to. Outpatients, right now, if you want to test them, groovy, that's fine if you want. I don't know how important it is, but and also it will be at this point something that will cause people to be quarantined or isolated. So better to say stay at home until you feel better, and then come back in 72 hours. So in some ways, testing, you have to decide really if you want to sort of pin that on somebody, or instead you want them to just do the right thing and go home. So for now, though, we're a sieve. You say send it, we'll do it. LabCorp won't even care. Whatever you send, they'll do. So it's going to be really about sort of triaging that resource, and it's probably going to change as we go. So in terms of hospital preparedness, plan for patient surge and preventing healthcare transmission of COVID-19. So part of that plan, and I know this is like hard to wrap around, although you all are nodding at me a lot, at least the ones in the room, having an N95 mask may not be the best way to prevent healthcare transmission of COVID-19. Having a more rational strategy at PPE that is available may be the better way to do it. So again, evolving that strategy is really important. It's not about the moon suit, it's about what you need that can be sustained throughout the outbreak. Priority, prevent nosocomial outbreaks. So all of this, Demetre is chasing this person whose cousin is here, who went to Westchester to a bar mitzvah and then went to a school, and I know everything about them. Soon what we're going to be doing is focusing on clusters and focusing on nosocomial stuff and working with the state as closely as possible, because that's where the money's at in terms of preventing transmission. 41% of transmissions in that Wuhan experience were nosocomial. Develop plans for the following: how to identify and monitor healthcare professionals with possible COVID-19 exposures, advocate for better strategies for furlough, because right now I think it's overkill, visitor management, healthcare worker self-monitoring. You want to incentivize people, and especially healthcare workers, to stay home if ill. So less stringent work from home policies, things that will allow you to be sick and get paid. Those things are important. You have to think about handling staff shortages, contingency staffing, and cross-training. You have to be prepared, thankfully not now, but if things get crazier, you have to think about triaging the use of ICU beds and ventilators. And then ultimately, in a terrible pandemic, you're going to have to think about altered crisis standards of care. So not just only triaging the use of the ventilators, but really deciding like who needs them and who doesn't, and making some very serious, difficult decisions that you will never do within a bubble, but would have a lot of support from ethicists and other support. So steps to take now in preparation. Did you know that you have a pandemic plan? You do. So it should be reviewed. And at this point, I would say, and I hope I don't get fired, it should be implemented. So start implementing a pandemic plan, like do it sort of in your phased approach, because usually these are phased approaches. Review CDC and other public health guidance, including ours. Implement triage protocols. So I saw a wonderful email about a way that it seems like it's through a portal that Sinai patients can sort of reach out. That's awesome. I saw that and I was like, this is a great model. So just that way there's interaction with clinicians that may not need interactions with healthcare, and figure out ways if you can evaluate people remotely, like if there's a way to do telemedicine, that would be amazing, or even use like, again, portal or other work. Assess PPE supplies and take steps to conserve. Part of that is advocating for the change in PPE. I think I've said that 40 times. Very important. Environmental protocols and supplies, make sure you got enough cleaning stuff, and then just-in-time trainings like infection control and PPE as necessary. And again, what you all are doing, when I walked in the door here, I feel like already the risk communication to patients, staff, families, and visitors is really, really good. I felt loved, but also prepared to wash my hands. So all very good. Check your guidance and resources often. So again, I'm going to plug our page, the New York Health Department webpage, the CDC novel coronavirus webpage, and then also, if you've not seen it, I imagine most people in medicine have, this Johns Hopkins University dashboard is pretty cool. And you can see what's happening live as you can with numbers and trends in coronavirus. Now, again, the plugs continue before I take questions, which is that you should have a very low threshold right now to call our provider access line. It's really best to call us when you have a person that you want to test. Specifically, I'll plug again, ICU level, hospitalized people we really want to hear about. But if you have, and all of the other things I said, the clusters and the healthcare workers, but if you have access to LabCorp testing, you don't necessarily, you shouldn't call us, because you can just order the test. Also, if for some reason you also practice outside, I think we may have people who practice outside of New York City, there is a New York State website that identifies the county health department, and then you can call the county health department to help you from there. And with that, although I have no idea what time it is, I'm going to thank you and open the floor for questions. Yeah.
You made a pretty compelling case for limiting testing, even as we expand our capacity to do so. How do you sort of balance that with the desire to establish a more accurate prevalence, so that we can have a more accurate true mortality rate to kind of allay public fears?
Right. No, I think that it's a really good question. I mean, I think you'll see that I think that some of the New York State numbers are driven by testing people who are very low or asymptomatic. Like the folks that we're testing tend to be pretty symptomatic because we're focusing on the care aspect rather than the case finding. So I think that really right now you should have a low threshold to test folks, but I think that's going to change. So it's more like giving you the lay of the land for the future. Like right now I think it's fine, but I think at some point from the resource perspective and really for what we need to focus on, it's going to be the sickest people and not the well people. I mean, like, I'll be honest, like we're seeing a bunch of people that you would barely test for flu who are getting COVID-19 positive cases on. And remember, I just sort of want you to think about it for a second. Right now, today, if I have a sniffle and a cough and you test me for COVID-19, which you should feel free to do, and that COVID-19 is positive, I get a quarantine order. I get an isolation order. Ooh, I almost messed it up. Isolation order, and I stay at my house. And I'm not allowed to go to work and all of that. So the other option is to tell people, if you're not feeling well, stay home. And you're achieving, if you think about it, a very similar goal. So again, party line, go for it. Test people, future, that party line is going to change.
Question for you. Thanks very much for that very informative presentation. What do you recommend for patients who are requesting notes to work from home in terms of patients who may be perhaps at higher risk?
Yeah, I mean, I think that there's a sliding scale. It's a hard question, and I think I would have you use your clinical hat. So there's higher risk, and then there's higher risk. Like individuals who have like cardiopulmonary disease, immunosuppression, that's like something that you're worried about. Like I put diabetes is on the list as well. I can't tell you about the control status, but like in this era right now, if it's feasible for someone who has like multiple comorbidities to work from home, that would be great. But there is some clinical judgment there, and we've been very we're trying to make sure that you have the ability to judge clinically. So I think it's okay to say no to some people. And then the people that you are the most worried about, the people that you'd be worried about who would do badly with flu, that's a good group of people to keep home. Is that an inadequate but close answer? Okay. Yeah, so if you're not sick, don't stay home. But if there's options, if they do have options to work from home, like if they can do that, like if their office, there's so many places that allow it, then, if they let you, there's no harm in doing it. Yes.
Hey, Demetre, we have some questions from online. So for the severely ill, is Gilead allowing remdesivir to be used on a compassionate basis instead of via the trial?
I believe they are, and I think it's through an IND, but I believe that they do.
Great. Another one's about kids. Do we know if children are being infected and if they are capable of transmitting the virus to adults?
So the numbers in China look as if children aren't super involved, but I think that we'll have to sort of keep an eye on what's going on in the U.S. and New York. Like we definitely have, and I think the mayor talks about ages, so I'm not hiding anything, or not oversharing. We definitely have some children who are diagnosed. So I think we saw a range that was like 22 to 80 something. Like I think we have someone who's like under 10. And so do they transmit? I mean, I think that we don't know everything about the virus. They probably are transmitters. Do I think that individuals who are asymptomatic are good transmitters? Probably not. Could there be some low-grade transmission from an asymptomatic? Maybe, but definitely this outbreak is driven by symptomatic people.
There's a question around clarifying around the transmission, and the person saying that they thought there's substantial evidence that the 2003 SARS coronavirus does exhibit airborne transmission, and what is the evidence around this one? So
far, what we're seeing in all of the bigger case series and all of the reports is that there's no airborne transmission. So I can tell you, though, SARS is different. So I think that this one, is different. And so new viruses can act differently, and different viruses in the same class can act differently. So far, the data look as if it's airborne. And I think, again, I also want to reference one of my favorite things is that the WHO, who is very conservative, have actually changed their PPE not to include airborne precautions.
So question around our chronically ill and immunocompromised patients and asking what the DOH is thinking around, talk a little bit more about postponing elective visits, routine checkups, and how they're thinking about that.
Yeah, no, I think that at the moment, the best guidance is for anyone who's symptomatic, who's like, so if you have people that you're worried about, see them. But like if there's a reason, like if they have multiple comorbidities, I think it's important to have like a lower threshold. But individuals who are well, like the main message is stay home. There are people, I mean, in my HIV clinic, like there are people who are technically immunocompromised, and now if they're calling me with like a little sniffle or a cough, I'm telling them to like watch how they do for a few days, and then if they're not better, come and get me. And so I think that that's like the strategy. I mean, we're gonna give that global. I think it's going up on the subway today. If you're sick, stay home for a few days and see how you do. And then if you don't feel good, follow up. But I think that even for many immunocompromised people, depending on their level of immunocompromise, that advice is good. People who are severely immunocompromised, just like in everything that we do, you change your threshold to lower for concern.
There's a question around the current estimate of the basic reproductive number.
Or not.
Yeah, the last one from China, they said was 2.2.
Mm-hmm.
They're curious about what it is.
It's so, depending on who you look at it, somewhere between 1 and 3, so 2.2 sounds great to me.
Gotcha. And then there's a question about sort of epidemiologically doing widespread surveillance testing to divine the prevalence in the New York State population.
So 2 things. So there's a plan to do some sentinel surveillance, which will give us a sense of the lay of the land of how, if there's I mean, actually it's kind of silly now, but to see if there's community transmission. I think I know the answer already, but we're going to do that. The real question about long-term surveillance. So interestingly enough, in the era that we live in, molecular biology and molecular virology is faster than serology to develop. So like they found this outbreak, they identified the sequence of the virus, and like soon thereafter there was a test. Apparently serology takes a lot longer. There are serological tests that are being developed, and I think ultimately when we're out of this outbreak, if I were a researcher, I would put in for the IRB now so I can do generalized serological evaluation of specimens that I may have banked somewhere, because you're going to find out that this is probably everywhere, but we're not going to really know until after this outbreak is over and when we have a serologic test available.
And there's a question around the threshold for increasing social distancing to avoid overload, like in Italy.
Yeah, so I think it's multiple data sources that come together and multiple different disciplines that come and talk about that. So I think that we're currently sort of looking at our pandemic plan and also what we're seeing with our syndromic surveillance, which I taught you about, and you all now know what that exists, and as well as what we're seeing with case counts to figure out when the sweet spot comes. The other part of this is if the severity is a part of that calculus too. So there's multiple data sources. So I'm not saying that this one is just like a little cold, but for 80% of people it is. But if it ends up that like some new virus comes in here and it causes people to have like their eye twitch, even if it's 100% prevalent, the eye twitch isn't enough to cancel things. You know what I'm saying? So severity is going to be a part of the calculus. So I think that it's not, everyone wants us to give a number, 20 cases, 40 cases, 60 cases, 100 cases. It's not about the cases, it's about the whole lay of the land, about seeing what syndromic surveillance is doing, what case surveillance is doing, and then that would be sort of some triggers. And again, these are things that we're discussing every day in our war room, and ultimately things will change as we go. So like right now, today I'm saying, social distancing doesn't involve canceling large events. Tomorrow, the next day, I may say, based on what we're seeing in our work, it's time to move forward with a change in what we're doing.
We have a question from...
These are great questions, by the way.
Yeah, there's lots of them.
They're good.
Question from one of our social worker colleagues.
Yes.
Thinking a little bit about seeing patients from the community setting, but those who come from either housing systems or shelter systems and having them in their offices.
So the question is
it people from shelters or social workers doing their work with people in the community who are in sort of shelters, community settings, having them in their offices here at Sinai?
So, I think that they're just like all other people. I think from the perspective of who they are, like we just give them the same level of care. If they come in the door and they have sniffles, throw a mask on them. If you can get them back somewhere safe, then they can go back somewhere safe. I think that it's really about things are going to be highly fluid depending on what happens with this outbreak. So, I think depending on where people are and where they live, everything can change. But for now, I think it's status quo. Nothing about them changes my concern.
For a final question, one of our pulmonary colleagues is talking about our Chinese pulmonary colleagues gave a lot of steroids, IV high dose, to mechanical ventilated patients, and reportedly works in their favor. And so wanted to address from a little bit more of an EBM perspective the systemic use of steroids.
Yeah, I mean, my review was that steroids ended up in some of the larger case series being less good. So we actually had some more untoward events. So if there's, again, I could be standing up here saying that, and a paper's been published in the last hour that I'm completely wrong about. But as far as my review of the literature and my scientific experts' review of the literature, like, steroids should probably be avoided.
Well, we want to thank Demetre for
Thank
taking
you.
time out of his busy days to come here and visit us, and to really be a Sinai faculty member in the front of this, and we're very proud to have
Thank
you
you.
there. So,
And again, I didn't get to say thank you for this, for letting me be here as a awarded person in this lecture series. I think it's an honor to be here, and it's always fun to come home. So thank you for having
well,
me.
welcome home. Thank you,
you.
Demetre.